and this is Michelle Hughes from Ageless and Timeless. Well, you know that what we stand for. It's all about living the best version of ourselves and using the most contemporary, cutting-edge biohacks. That's kind of a slang word these days, but anyway. But we try to find all the ways that we can live better and longer. And so today my guest is Dr. Betty Murray, and she exemplifies exactly what I just said. So we're going to talk a lot today about how we maximize our opportunity to live better and longer. So Betty, welcome to Ageless and Timeless.
Oh, thank you for having me. I'm so excited to be here.
Well, Betty is, Dr. Betty Murray is from, well, you're from Dallas. I mean, is that where you grew up, Betty?
I actually lived all over the country. I'm originally from Northern California, but
oh, that's right. You told me that.
Yeah.
All right. So we were neighbors. Which town was it?
Walnut Creek. So I was born in Walnut Creek.
I remember you telling me that. Okay, so you're a transplant down to Texas.
That's
like
right.
So many Californians these days. So, Betty, why don't you start us off by telling us your journey in as simple, concise a way as possible. How did you go from there to here?
Yeah, I moved around a lot as a kid, but, my journey into healthcare really came out of my own illness. I hate to say that, so many of us that sort of go into the functional medicine arena, longevity, biohacking, it's because the current conventional medicine sort of failed us. And, I was actually swept into the technology boom in the early 90s. So early 90s. And so while I was working for a company as a first female hired by the CTO, it was 100 hours a week, a very brutal environment. I was diagnosed with colitis. So what was once kind of an episodic digestive problem became much worse. And I remember when I was sitting in the room and the doctor, I was asking the doctor if I could change my diet because I didn't want to go on the medications. I was like, these are really harsh. And he barked this laugh in my face and said it had nothing to do with what I ate.
Oh.
And of course, you'll get to know me. I had some choice words. I was a little bit colorful. And,
right.
I walked out of that and I spent my time, weight training and I was into diet and nutrition. That's what I read about all the time. And so I just started taking nutrition classes first at a kind of a community college. Then I found a university online and ended up going back and getting a certification and a master's in human, basically nutrition science. And I opened our clinic, so I've had a clinic for 21 years in Texas and in North Texas, and we really helped predominantly women, especially in the very beginning, with complex health problems. And then when I really entered into, so that was my mid-30s, I entered into my late 30s, I started having a lot of hormonal problems. At the time, even though I was connected in the functional medicine community, I had access to the luminaries, I'm an OG in that community. What was really going on is I was in very early perimenopause after a tubal and some other stuff. We can go into it. But at the time, I was told it was everything else. It's your adrenals, it's your thyroid, it's your this, it's your that. And what I really recognized very quickly is, all of the chronic disease that really affects people early in life is very, very expensive and also very, very disruptive are predominantly female. Right? If we look at autoimmune disease, it's 10 to 1 female to male. And if we look at kind of chronic disease, women tend to live longer but have poorer health span. Mm-hmm. And so in my late 40s, I decided to go back and get another master's and Ph.D. Really the Ph.D., but you have to get the master's just in case you don't finish the paper. So I got another one of those. And I was really studying hormone metabolism, so how our body processes hormones and the impact on disease and longevity. And then I specifically looked at the impact at IBS for women. And so everything I do now is really to move women's health forward, particularly for the midlife woman, because we get less than 1% of research dollars. And so we have a huge gap there. So that's my kind of place. And it was because my perimenopause was so terrible, despite being highly connected. I kept looking at it and saying, God, if I feel this bad, how does everybody else feel?
Right. So what happened with the colitis first and then the hormones?
Yeah. So the colitis, for me, several things were triggers for me. So I ended up later on being diagnosed with celiac. So I'm a celiac and I have some other foods that really, really trigger me. The microbiome was kind of out of whack. So through nutrition, supplementation and, really being clean, I've been able to control my colitis. I don't have to be on medications, and for the most part, I'm in remission. And then, for me, I ended up getting a tubal because I didn't want to be on birth control, but I wanted to control my fertility. I wanted to control that risk. And I had to fight for it. Doctors were like, you don't want to do that. I am in Texas. And so somebody else feels like they can tell you what your fertility journey should be. Mm-hmm. And so when I finally had it done, they said, nothing will happen to you. Like, we're just going to cauterize those fallopian tubes. Well, lo and behold, within about 6 months, my hair started falling out. My periods started coming closer together. I literally gained like 35 pounds. I used to live in the bodybuilding community, so I know how to manipulate body composition. Right. And as a nutrition professional, that was just hard swallow, right?
Oh, absolutely. And you couldn't, and nothing you did would change it, right? Because it was hormonal.
Right. And so now at 56, I have no visible ovaries, and I've never had them removed. My body reabsorbed them. So what women don't get told is when they go in and whether it's a hysterectomy and they leave the ovaries, or they go in and cauterize, or you have any kind of surgical intervention, a lot of times the blood supply and the nerves to those organs will get damaged, and your body will reabsorb them. They dry up like a walnut and get reabsorbed. So, I think what happened is that pushed me into a very early perimenopause. I looked more estrogen dominant, if you've ever heard that sort of conversation piece. Of course. And so, I was on this journey, and I think a lot of it was I was being told and managed as if I was very estrogen dominant. And I think there was a lot of chaos there, but I think I should have started estrogen a lot earlier. But I went into basically early menopause despite having all my parts, And so, I understand when women are like, I don't understand what's happening to my body.
Right. So define for the people that are watching today, define estrogen dominance.
Yeah. So we have 3 major hormone groups. So we have, when we're talking about sex hormones, we have estrogens. Of estrogen, we make 3. The one that's most protective is estradiol. That's the one your ovaries makes. Mm-hmm. And then we have a counterbalance hormone called progesterone. And progesterone's job is to sort of fluctuate with estrogen and prepare the uterine lining for implantation if you happen to fertilize an egg. Mm-hmm. But progesterone has impact on the brain and other things. And those 2 hormones fluctuate throughout your cycle and throughout your month. Mm-hmm. And then there's also testosterone. It doesn't fluctuate as much, and it does decline, but declines more slowly sort of over time. And often when a woman gets into her 40s, when she starts in that sort of perimenopausal journey, progesterone is the first hormone to decline. So it starts to decline because you do not always ovulate, so the egg doesn't always fly out, and that is required in order to make progesterone. And so by default, many women in their midlife, in their 40s, they're going to be estrogen dominant relative to their progesterone. Mm-hmm. And then as you get into sort of late stage menopause, you start to have wild fluctuations of estrogen, then estrogen starts to decline. Mm-hmm. Here's the thing, Michelle, that no one tells you is you could still be having a cycle and still have low estrogen.
Really? Why is that? Explain that scientifically.
Yeah, so essentially we have 2 hormones that come from the brain. One's called FSH, follicular stimulating hormone, and the other one's called luteinizing hormone. Mm-hmm. And think of those as the coaches or the instruction manuals that tell the ovaries, "Hey, we're gonna shoot an egg out," right? Mm-hmm. So FSH and LH in particular causes the ovary to swell, to create a little follicle, and then to shoot the egg out. Mm-hmm. Well, what happens is we don't get appropriate signaling there, and then we don't always have an egg come out, right? That can be because we are running out of eggs, and so we're a little bit low, or they don't fully develop, right? So we're born with our eggs, but they go through sort of this dormancy phase into a live phase each month. And so if that happens, we don't necessarily have an egg fly out. We don't get progesterone, so we don't have as much rise. So in many cases, women in their late 40s are having the estrogen fluctuations that are being driven by FSH and LH, but they're not really ovulating. But they'll still have a cycle because their estrogen is still fluctuating. Mm-hmm. And really, I don't think we understand that well enough. We haven't done enough research. So a lot of women are sort of waiting until their periods stop before they intervene. But the reality is their overall levels of estrogen throughout the month are likely low compared to
And then and when the symptoms of that, if they were just looking at symptom related to estrogen decline, would be what? Cellular protection is a key component of longevity, and that's where C60 enters the conversation. Known for its powerful antioxidant properties, C60 is being explored for its role in reducing oxidative stress and supporting cellular resilience. As interest grows around mitochondrial health and aging at the cellular level, C60 continues to stand out as a fascinating area of research and application. It's exactly the kind of forward-looking wellness solution we aim to spotlight on Ageless and Timeless. For more information on C60 and how it's being used in longevity-focused routines, check the affiliate link in the show notes or use Ageless10 for 10% off your purchase of all their products.
So it could be, you know, obviously that most people think of what we call the vasomotor things, the hot flashes and night sweats. However, that's not the first ones that show up. I would say the most common symptom you'll hear is, I don't feel like myself, right? It's this sort of gray, not quite sure. But when we look at the studies, the most prevalent symptoms are brain fog, anxiety, depression, sleep issues, fatigue.
And what about weight gain too, right?
Yeah, weight gain doesn't get its fair due. You know, you've got a lot of the other kind of science side that it's all about calories in, calories out. But we know that the loss of estrogen affects insulin sensitivity. It affects your powerhouses, your mitochondria. It affects your body's ability to burn fat and sugar. I mean, so weight gain is a big part of that too, in many, many cases.
Right. Yeah, because the A1C levels, the insulin levels and glucose tend to increase, right? Because of the estrogen is not helping to keep them at a normal level.
Yes.
So the low estrogen causes more insulin sensitivity, is what you were saying. Okay, so go on and just keep telling us more.
Yeah. So actually, it's you know, think of your hormones as kind of like the three little bears. We want the porridge just right. You know, so too much estrogen can cause insulin resistance. Too little estrogen can cause insulin resistance. It's about kind of that having that right range. And so for a lot of women, we experience that sort of weight increase and all those other pieces. You know, the other thing that I think is most insidious is women will start to experience the mood issues. So anxiety and depression, like 3 out of 5, you know, 4 out of 5 will experience some period of depression and or anxiety. And I think what we don't realize is how much that impacts how we feel about ourselves and then how we show up in relationships and work. You know, we have this huge brain drain that also happens in entrepreneurship and corporate America because women are now at their kind of pinnacle of their success and they're starting to have all these symptoms and there's a significant portion of them that will walk away from, you know, advancement because they're like, my brain's not working, you know? Right.
So what did you do about it, and what do you recommend others do if they're facing that right now?
Yeah, so I think the thing that women need to understand is that the average woman experienced the symptoms of menopause for 8 years. And that's really happening in perimenopause, right? Because menopause technically is 1 day. It's one year from the last time you had your cycle. So the average woman's going to experience that for 8 years. You know, for me, what really helped me was getting my hormones balanced and actually putting estrogen in, despite the fact that I fit this sort of position or experience of what everybody thought estrogen dominance would look like. So getting estrogen on board, dialed in, and also having less of my own natural fluctuation. When you're in that second half of the cycle, your ovaries, I like to call them like a bungee cord. Today it's high. Today it's low, today it's high, it's low. So your ovarian function and your production of estrogen is so volatile. A lot of times you might feel good one day and not the next. When you put estrogen in and you even out those peaks and valleys, because you've got like a low level that you're also supporting, you create less of that and you get less chaos in that zone. We don't have really great research. I mean, that's why we're building Menrva, is because we want to be able to get the research to really be able to do that with precision. So hormone replacement, I think every woman, regardless of age, should consider and be evaluated as an individual for hormone replacement. The vast majority of women would benefit, regardless of age. We have women that put on hormones 20 years ago that are in their 80s and they're rocking and rolling.
Right. So what about, so with estrogen, let's dissect it a little bit more. All right, you said estradiol, but go ahead and talk about the three estrogens and what they each mean and how they each influence the overall effect of the outcome.
Sure. So estradiol is the one that's most protective. So that's the one that's made by your ovaries. We also have another form of estrogen that is made by your fat cells, predominantly called estrone. And estrone in your tissues can be converted to estradiol. So if I have estrone in my breast tissues, my abdomen, my belly fat, my body can convert it if necessary to estradiol.
When would the body know to convert?
It's going to do that on its own. I would say we don't necessarily understand exactly what triggers that activity. If we think about what estradiol really is estradiol has the primary function of metabolic function. So like driving mitochondrial function, driving, brain cell function. And so, but the challenge is estrone, if we're heavier, let's say, we'll make more estrone. When we go through menopause, estrone is the primary hormone that we make. And it's more pro-inflammatory. So it doesn't have, so think of your hormones as keys, and every single cell has like a lock and key. Estradiol is the perfect key, and it makes everything work perfectly. Estrone is kind of like a broken key, and you sort of have to jimmy the lock. It can attach to receptors, but it attaches to some of the receptors that are less favorable. So you don't want a ton of estrone. There's another one called estriol, and that one is made through the detoxification pathways in the liver. So it's part of your body's sort of packaging of these hormones once your body's done with them to go into the trash. Estriol is generally not very high unless we're pregnant, but it preferentially attaches to a receptor called estrogen receptor B, and that one is considered cancer protective, right? So we want some estriol circulating, and then you've got estradiol that attaches to both estrogen receptor A and estrogen receptor B, right? So it's never one or the other. So when you're replacing hormones, we usually do an estradiol, and in our world, we also do estriol because we want some of that estrogen receptor B attachment, basically.
Yeah, you don't want estrone. You don't want to, add estrone. So I always, when I was first learning, I remember there was like a 1, 2, and 3. Yep. And 3, I think, was the estrone, right? And you never wanted to add the 3, only the 1 and the 2.
Yes.
So in the formulations, just to take it one step further, in the bioidentical world, the BHRT, what form of estradiol, which is the most common one, let's just take both of them, okay, 1 and 2. What form do you prefer for absorption and the other outcome of effectiveness?
Yeah, we use for our company Menrva. So Menrva is the telemedicine company in all 50 states. We use a bioidentical hormone in oil, and so we use a combination called Biest. So Biest is a combination of estradiol and estriol. Right. And the good thing is because it's compounded, we can change the composition of the amount of both of those, so we can hit both receptors. Right. Now, if you look at the bioidentical forms that are often used by other practitioners, like the patch, it's solely an estradiol, right? Yeah. And so at a minimum, we have to have estradiol because that's the one that provides the primary function systemically. But I'm a strong believer because of the biochemistry that we also need estriol.
So when you say an oil, how do you take that? Is it something that you put under your tongue, or
Topical.
how is it
Yeah.
used?
Yeah, so it's topical. So it's a topical, almost like a cream, and
Oh,
it's in an organic jojoba oil. So it's
okay.
literally
And
this
is it
company.
coming?
Yeah, it's patented. So it's a patented, all organic, prescriptive hormone and jojoba oil are the only ingredients.
And Betty, why did you choose that over, let's say, sublingual troches or injections or other forms of application? Why did you choose the topical?
We've used all of them. So, and I will say, even myself, I'm kind of a human guinea pig. I've used pellets. I've done it all because I'll do it and then I run labs and see what happens. Like,
Right.
and here's the thing: is most all of whether it's injectable or whether it's the patch or even compounded creams have endocrine disrupting ingredients in it. There's solvents to keep them in suspension. And so to me, it was always odd and less than favorable to go, oh, I'm gonna give you a bioidentical hormone, but I'm gonna give you an endocrine disruptor at the same time because those things disrupt your sex hormones. And so I went on a search to find a cleaner source, right? And so when I found this company, Bright, which is the pharmaceutical company that produces this, they literally had just the jojoba oil and the hormone. So I was like, okay, they're patented internationally, worldwide, to deliver hormones and oil. They're the only company patented to do that. And I was like, this is fantastic, because the other thing is a lot of your creams don't absorb very well. Depends on what the
Right.
base is. So a person might get it
Exactly.
from one company and it works great and then not another. Jojoba oil is a waxy oil. So
Right.
it sits on the skin and absorbs very rapidly. And so
Right.
it has a very uniform absorption. And so we tested it for 2 years in our clinic against, other forms, whether it was compounded or patch or whatever, and really found it to be very, very effective and the cleanest form. So that's our primary hormone that we use.
And where
And then
where does the estrogen derived? Is it from yams?
it is, it is a vegetarian form, so it is a vegetarian, what is traditionally used in almost all compounding. There's
Ah,
from a chemical standpoint, everybody uses roughly the same derivative.
right.
Yeah.
So okay. So how often do you use it, and how much?
Yeah, so it depends on the woman, right? So one of the things that was always frustrating to me even when I started our clinic back in 2005, I sat down with the physician because I'm a PhD. I'm the science side of the medical side. And I was very excited that we were going to be doing bioidentical hormone replacement. And I sat down and I was like, okay, tell me how we calculate this because we're compounding it. And I was really frustrated because it was like, well, we started a low dose and then we check symptoms. And, thankfully we look at labs. A lot of clinicians do not. And then we sort of guess our way into the right dose. And I can tell you this, Michelle, that hasn't changed in 22 years.
I
It's
know
still the
it's sad.
same damn way.
I
And so
know.
here's what we do know. So this is why we're building the technology platform. We're going to capture this for each individual woman so we can actually be predictive, right? But so in most cases, we apply estrogen twice a day, right? So in the morning and at night. And it's because estrogen has a relatively short half-life. It's not as short as progesterone, which is extremely short, which we still do orally, but it has a short half-life. So a lot of times if you take it in the morning, the dose may be worn off by night and it might affect your sleep. And so we dose a little bit in the morning and a little bit at night. We do progesterone a lot of times at night, oral, micronized, because it helps with
Right.
sleep. And then testosterone, we will usually dose in the morning because it has a much longer life.
Right.
And in most cases, you're using it like on the forearm and then the inner thigh.
So the testosterone is also a cream.
It's an oil, yeah. So it's an oil
It's
base.
same thing. And
Yeah.
what's the name of the compounding pharmacy that you?
It's an exclusive pharmacy. It's called Bright. Yeah,
Right. Like
yeah.
Bright.
TE or
Okay.
BRITE. Yeah.
Oh, TE. Right.
Yes.
Okay. And so you're saying they're the only one that you could find that had the
Yeah, they have
didn't have
they have an exclusive worldwide patent on delivering hormones and oil.
on the with the jojoba oil. Which what I don't understand why how anybody can go get jojoba oil and put it in their formula. So how do they start? How does
Well, I
the
mean, if it's
patent?
patent, so they're in patent. If somebody goes and does that, they're violating their patent, which means
I
they'll
mean,
end up.
that's incredible that they would get a patent
Yeah, yeah,
on
they've
an
had it for a
oil that's so
while.
I
Yeah, they've had it.
know.
Yeah, I was surprised, but I have been looking for the cleanest possible, delivery, and so A, the delivery is great, and B, we saw really, really great results in lab work and also symptoms, better than creams, because creams are kind of all over the place.
Hmm.
Injectables, sometimes you get peaks and valleys, and pellets are very easy to get too high and hard to
Yeah.
control. And
Yeah.
so,
And
yeah.
my functional medicine doctor in Beverly Hills, she does not like the patches. What did you come up with as far as conclusions about the patch?
I mean, the patch is like if we looked at your Menopause Society trained physicians, that's their go-to. But here's what we have found is, most of these are all generics. The generics change all the time. The absorption is radically different between brands. Some of them are just horrible, right?
Hmm.
You can get, patch adhesive interactions. So some people get rashes and things like that. I will say some people really like them, right? So our product may not be perfect for them, but we have found that it really depends on the brand, and those pharmacies are constantly changing brands because it's whoever gave them the lowest price this month. And
Hmm.
so and right now we have a patch shortage, you know?
Oh, because of the supply chain, you mean?
Yeah,
Is that
supply
because
chain.
is that because they're coming from China?
Well, it was occurring before everything that's happening right now, but all of our pharmaceutical drugs, almost every form of generic drug is actually made in India, and a few that are made in China.
That's
And
right.
so our supply chain is 100% outside of the United States in most cases, and so we are subject to what's going on. So between tariffs and the chaos of world wars and all of that, that does it. But I think the other part is I think they failed to pay attention to the FDA lifting the warning.
Hmm. And so, how do you integrate the other hormones, DHEA, pregnenolone, thyroid? How do you get it all to be in balance? It's like being the conductor of a big orchestra, and you have all these individual instruments, and they're all playing. They have to play together in order to be a symphony, right? So, how do you manage to get all of that in balance with individual customization?
Yeah, so I think this is where a lot of people miss the boat, right? When they start looking for hormone replacement therapy, a lot of clinicians out there just go, "Oh, you just need sex hormones, and as soon as your hot flashes go away, you're perfect." And I'm like, "These aren't magic." Right. And
Right.
here's the thing. We have a great quiz that we're developing that helps a woman understand, because 9 times out of 10, the analogy you gave is perfect. If your sex hormones all of a sudden showed up and the orchestra thought they were playing a waltz and all of a sudden they're playing jazz,
Hmm.
all the other hormone systems start to freak out, and they're trying to
Hmm.
balance, they're trying to bring harmony. So most of the time there's other hormones that are out of balance, the thyroid or the adrenals or the insulin hormones, or we've got an inflammatory response, and if we ignore that we miss it. And so
Right.
we test for all of it, we look at
Right.
all of it, and we're adjusting for all of it. So we also are very, very precise about replacing thyroid when necessary with the right combinations for that person to get the right levels, and
Hmm.
addressing the diet and lifestyle to make sure those things are dialed in. Adrenal function and cortisol is a big part of
Hmm.
that, because
Right.
menopause is a high cortisol time period, like
Right.
because you have no recovery hormones. And so if
Right.
you automatically already have other things contributing to that, you're never going to feel awesome even if you get sex hormones on board.
And do you get a lot of resistance from women to taking testosterone?
I think we've done a really good job of explaining the necessity of testosterone, and just the myopic view of the FDA that it's not necessary for women. Most of our women really want testosterone, because they
Hmm.
recognize that it's a brain hormone first and foremost, right?
Right. Yeah.
And so we don't get a lot of pushback there, you know.
Well, and also with the GLP-1s, and the sarcopenia threat, muscle loss, more and more more and more women are realizing they need to get testosterone, because that helps with not only with their libido, which often has a negative impact in menopause, but really with the muscle building and
Yeah.
maintenance of muscle, because muscle loss is probably one of the biggest causes of aging.
Yep.
And
Right.
the GLP-1s, have only accelerated the potential. So protein,
Yeah, and
one
lift,
option, but
lift. So pregnenolone. So pregnenolone, I don't think gets its fair due, right? So pregnenolone for everybody, that is the parent hormone or the precursor hormone for all of our other hormones.
I know. And why is it that it gets so little attention?
I think a lot of it's because we really haven't done the due diligence on studying it. It's highly concentrated in the brain. It's the precursor. It really deserves a bigger due, right? Because even when you look at what's an optimal level, I wouldn't say that we have really great research to say it, right? Like from even a functional standpoint, we always like it on the higher end, but could we possibly point to and say this is why? We don't have that, but it does get missed. And DHEA also, the thing
that was my next point. Yeah. So go ahead on DHEA, because that, again, it's, oftentimes not even tested. And then there's always this distinction between 7-keto DHEA and regular DHEA. Regular DHEA is what helps with the sex hormones. But oftentimes doctors give you the 7-keto form, which doesn't do anything for that. No. So I think there's so much confusion, but just talk about DHEA for a moment.
Yeah, so DHEA is really a counterbalance hormone. It's your primary anabolic hormone to offset cortisol. Yeah. So its job is to really support responding to stressors and getting back to an anabolic state. And it is the precursor for testosterone and androstenedione. Right. 7-keto has been shown in early studies in the 90s to help a little bit with lean body mass, but it is not a precursor to your other hormones. Right. However, what I also want to say is, as a lot of, especially telemedicine companies that haven't gone down the road to prescribe testosterone, like we do it in all 50 states. Yeah. But they will lie to women and say DHEA is equivalent and we can help you raise your androgens. And I'm like, I have yet to see that raise testosterone enough to be any bit functional without causing hair loss and acne and a bunch of other things. Like they act independently and they are different. So we look at it. We look at DHEA sulfate. We look at the levels. We restore it. And for the most part, women don't need really high levels. We just need consistent levels.
Yeah, so what do you consider to be a good level of DHEA?
It depends on where you're looking at it. I prefer it in urine. I prefer looking at DHEA sulfate in urine. And if we look at like the Dutch test, their reference range goes for a midlife woman goes from like 30 to I think 750, which is crazy. Wow. I like it in, if you look in blood, I like it in the, 150s and up a little bit.
That's where I am. I'm 160, I think. But what about, so let's talk about the big T, thyroid. That's probably one of the most underdiagnosed conditions in our medical world, on the allopathic side. But even the functional medicine people still miss a lot about, you're just aging. But yet, I feel badly. My hands and feet are cold. I'm gaining weight. I have bad moods. And then your thyroid gets tested and it's normal. But yet it isn't really normal. So how do you deal with that? I'm sure that you face this frequently.
Yeah, and I think, if we look at conventional medicine, they just look at TSH, which isn't even a thyroid hormone. It's a pituitary.
I know.
And then if they look further, they look at T4, which again is not an active hormone. It must have an iodine molecule removed. So the first thing is testing all the way to free T3 and looking for antibodies, right? And reverse T3 to see, because reverse T3 is sort of a fake version that blocks the real hormone. So it's very important to see that and adjust accordingly to make sure that we get that T3 level up into a therapeutic range, because a lot of people get prescribed things like your Synthroid, levothyroxine, which never raises their T3, right?
And it's only T4.
Yeah, and so that depends on the IDO gene and whether you can actually convert very well. Like I have mutations on all of them. I don't convert T3 very well. So I take an NP thyroid plus Cytomel or compounded T3 I take twice a day. Because T3 is a very fast acting hormone. And so its half-life is short, so you might need to dose it twice.
So what I do, I take the NB as well, the natural. I never take any pharmaceutical drugs if I can help it. Yeah. But I've been on 2 grains now. Do you think that's a little too high for I mean, my thyroid, my T3 was like 2.25, I think, on the last test.
Okay.
That's a little bit low, isn't it? Borderline
It's
low?
yeah, that's low. Yeah, that's
Yeah.
still low. The thing is so like if we look at NP thyroid or Armor, they're done in grain size. So what I would say is it depends on how much you need to get into your right amount, because you could be on 1 grain, 2 grain, 3, 4. What may be more important is NP thyroid has basically a little bit of T4 and a little bit of T3.
Right.
Except you still may not convert your own very well, right? So if you're on that and it doesn't seem to braise it, that's where it might make sense to put some just separate T3 in. Because that's where the rubber hits the road, is truly getting that T3 level into a range that works.
And Betty, what about T2?
Yeah,
Nobody talks about that.
Yeah. My friend, Dr. Amy Horniman, I would say is probably one of the experts in this arena, but T2 is also metabolically active, but we don't prescribe it.
She's a really good friend of mine too, and I knew we had her in common. I remembered that from when we first talked, but she just this morning had an email out. You probably got it about how to recognize T2 and how to supplement for it if you need it. Yeah. But how do you know if you need it if it doesn't get tested on blood work?
No.
So how do you know if you need to add T2 to your protocol?
Yeah, what I think about is if we've done Armor or Nature Thyroid or NP thyroid and we're not getting better, then we look at T3, right? And we're not getting better. Then a lot of times at that point it might be worthwhile to try a T2. I think the hardest thing is whether the FDA is going to come down on that being over the counter.
But she has a supplement in there, her fixer formula,
thyroid fixer,
just T2, and she actually touts it for weight management quite a bit, which I think gets a lot of attention from a lot of people, but may not be the only reason you would ever want to take T2, but I think the most important thing that we have to let people understand is that T4, which is normally what these drugs are ingredients are T4, it's a passive hormone. I mean, it doesn't do anything. It's just a reserve. Right. And if you don't convert T4 to T3, which is the active form, then you're not going to have the results with your symptoms being reduced. And then you've got the TSH, which, like you said, it's a pituitary. It's not even a thyroid hormone. So why and how have they come to measure only that to look at your thyroid and not the rest of the picture? Why do you think that happened?
I think if we look at how medicine sort of evolved, most of our what we would consider Western medicine or conventional medicine came out of warfare and infection. And then it came out of drug development. It was really Kellogg that did that. They did the Flexner report and sort of, undid a homeopathic and chiropractic and other schools that rivaled the amount of medical schools we had back in the early 1900s. But essentially what happened is drug discovery and pharmaceutical companies really took hold of the medical community at that point. And so, for instance, Armor thyroid was grandfathered by the FDA because it existed before the FDA. Well, along comes Synthroid, right? Synthetic, patented, now it's generic, but so there's always been this pushback because the pharmaceutical companies want control. And because of that, they control the education, they control the testing paradigm. So, what gets told the doctors that is considered standard of care. And so it really leaves the personalization out, which is inappropriate at this point. We have the capacity to personalize medicine to the biochemistry of the individual in front of us.
So when you put the hormones into the big picture of your overall health and wellness, well-being, how do you integrate that? How do you describe to your patients where the hormones fit in all of this? Because there's so many other aspects of good health. But so tell us how you describe and help your patients to understand the importance of hormones.
Yeah, so we have to remember that our entire body runs on hormones. So I like to think of it this way. So if we all remember Katrina, right? So Katrina was catastrophic, massive destruction. what's the first thing that they put in when they started to like recover Katrina? It was communications, right? They restored line communications, cellular communications, walkie-talkie, all of that stuff. Your hormones are the communicators in your body. So they communicate between cells, they communicate between organs, and they're the ones that tell things to do things. And so when we lose those primary sex hormones that are because of aging, right? We weren't designed to live 35 years postmenopausally. We just weren't, right? Our life expectancy has far exceeded our ovarian age. And when we lose those, what happens is all of the messengers that say, hey, stay vital, keep the mitochondria cooking, keep everything moving at high speed and keep me young and fertile, goes to sleep. And then all the other messenger systems like insulin as a messenger and as a communicator, all of them start to go sideways. So when you restore hormone function, not back to a 20-year-old, but physiological, right? You get enough in there so the body can do what it needs to do and gets the right messages. That then allows for all the other stuff, right? I also hear practitioners all the time will say, well, they have to earn their hormones. Like, I won't put you on hormones until you do XYZ. I'm like, put them on hormones so they can go to sleep, get to the gym, not want to scream at their children. Like the hormones are so important. Every single cell but 2 has an estrogen receptor. Right.
And what are the 2 that don't?
There's a single cell in the brain, like one of the, I can't remember, it's not the glial cell, but there's a single brain cell that doesn't have a receptor, and red blood cells. Everything else does.
Oh, really? I didn't know about the red blood cells. Yeah. So how do you? I always say the hormones are the superhighway of your body. So you just cannot function if your hormones are out of balance. So to me, it's like the foundational step. To good. Well, first getting your genetics tested, so if, like you said, you're a slow converter, and so that helps you to know how to then dose for that deficiency. Right. So I always say that your genetics tests are it's like building a house. I was telling my girlfriend that I was referring to you yesterday. I was telling her, you wouldn't build a house without a foundation. Well, okay, so know your genetics because they don't change. Right. Now, epigenetics means that you can live, you can, I have the obesity gene, and I'm like a size 6, weigh 115, and I'm 5'6". So, it might have been in my family, but I've been disciplined enough. So epigenetics is how you make choices for your lifestyle. So, but anyway, the point I was making is so many doctors, allopathic, do not even ask you to test for your hormones. It's just like to me, that's such a crime against humanity. So, well, then talk a little bit about stress, because today's world is so stressful, and everybody is talking about the gut-brain axis and how peptides are changing the mitochondria and the metabolic terrain, but yet still stress is still the killer. Yeah. So I know you deal a lot with it and you're dealing with women who are hormone deficient, so stress is going to be one of the big complaints. So what are some of the conclusions and some of the protocols that you use for stress management?
Yeah, if we look at, because we do genetics and then we look at your epigenetics, so your phenotype, the combination of those two things, and when we look at it from a hormonal sort of phenotype, I would say 60% of the time there's a cortisol issue, right? It's just, because none of us had the last 3 or 4 decades that weren't stressful. And so, but the challenge is, and I'll tell you from my own experience, I'm a type A hard driving. I'm not type A necessarily with my family, but I am frighteningly driven. Yes. And so I was very much one of those people when I was younger that I'll sleep when I'm dead, right? I was like, I don't sleep well anyway. Who cares? I'm just going to keep going. Right. But here's the thing. There's not a supplement. I don't care what somebody sells you. There is not a supplement on the planet. There is not a drug on the planet that can override your body's need for rest and restoration. Right. And so, we have to look at it. So we have to identify what's going on, your metabolized cortisol, the free cortisol, but we have to ingrain the lifestyle on top of it to help, right? Yeah. So we have to, one of the things that I see, Michelle, all the time is boundaries, right? that's like one of the most powerful things for a woman to do is to finally say no.
There's set boundaries, right?
Yes.
And the willingness to say no, like, you're so right. You're so right.
Yeah. And so we look at all of that. So we have, the women that work with our telemedicine company, we do the hormones, we do the thyroid, we look at the adrenals, we look at the gut, we look at the genetics, we look at all of that. And then we also have community, we have health coaches. And part of the health coach's job is to help you get through enabling yourself to get better, right? Because we have to often get better in an environment that makes us sick, right? And so I think that's so important, is that we have to understand. And I think some of the beauty of midlife is, we are less accommodating of other people's BS anymore, which is beautiful. I was like, pull on that cord, right?
Yeah.
Just don't. And put yourself first a couple times, right? So we can start feeling better, because this is really the time period of life where we have agency. We have more agency than we ever had. Our ability to make decisions about our own life. We have access in many cases where we didn't have it before to things, and we have assets. And this is the time in which to use the assets to do the things that we want to do. And so it's
like if you need an answer to a question, just go on ChatGPT. You're going to get at least one version after they, source the whole internet. But it comes in a nanosecond, so your impatience to get answers is completely quelled, because you no sooner have the question on the page than you're having the answer. It's just kind of amazing. Well, does Menrva use all of this AI, and how does that all work?
Yeah, so right now, Menrva is really two sides. So Menrva, on one side, is the telemedicine. So we have menopause method trained physicians and clinicians in all 50 states that provide bioidentical hormone replacement. And they work together with our nutritionists and health coaches, and we help somebody get and stay well, looking at genetics and hormone testing and all of that, so we get that dialed in. And on the other side, this is the technology we're building. So we raised capital, and we're still raising capital, but we raised capital, and so this we're hoping to be out by September. The first stage of it will be an app. So imagine you download an app, and you're going to capture some information about your own symptoms. If you're wearing wearables, right, you can capture all that information. You can connect all of them. If you're like me, I have multiples, so I have bunches of those doing that. And what it starts to do is it's using AI, and it's constantly reading what your experience is, what responses you have, what do your wearables say. If you took a picture of your food, what's your macros that you're eating? And it's giving feedback. So it's giving feedback to you, and also giving feedback if you're working with one of our clinicians. So your provider knows exactly what's going on. But ultimately, what it allows a woman to do is order her own labs, look at her own wearable data and CGM and all that stuff, and understand her own body as an N of one. Right? And we can get predictive, proactive, and preventative, right? We can start telling you, we can get in front of it, and we can say, hey, Michelle, we've seen this trend happen, and these three things are going on, so here's what you should do next, right? We can get to you before it becomes a problem. And then ultimately, if somebody's working with our telemedicine team as we build this technology, we're also going to capture, what are you taking? Medically and supplementally, how do you metabolize those hormones? Because that's where my Ph.D. Research resided. And then how are you taking your hormones? So what dose did you start at? What dose did you end up at? So we can actually collapse that gap and be able to say, based on all this data, we know the dose that you should be on, right? And we can get closer instead of guessing. And so we're building that technology right now. So we'll essentially be able to, privatize health to women from the comfort of their own hand, right? And their own phone.
You say 50 states, but that's not a small task. How did you ever get certified? Talk about a type A personality. How did you type A to get that done? So how did you do that?
Yeah, so personally, I'm a Ph.D., so I'm the science behind the entire thing. So obviously I have clinicians that work for me in my clinic in Dallas. So we have a clinician team. So we have a team of providers that are licensed, because each state has separate licensing. So they're licensed in all 50 states. So we have a team of medical providers. I don't actually see patients anymore. Right. But we have a team that are all trained, certified. They know exactly how our method works. And so that allows us to then deliver. But then when we have the technology, we can hyper-personalize for every woman.
Mm-hmm. So how many patients do you have throughout the 50 states?
Yeah, so we so this last year, so we built the telemedicine side first. So we brought on 100 patients as sort of our first cohort. And then we are launching kind of the newest version of our systems and products and the new pharmaceutical. We're launching that in the next month. And so that will be the new one, and we're going to start bringing on a lot more patients. So
let me be sure I understand this, Betty, so for everybody else too, that, maybe it sounds redundant, but you're saying that when you had the vision to build Menrva, you saw that 50 states was your universe.
Yeah.
That's where you're starting. It's not international, it's 50 states. But you then went and hired clinicians in each state that were certified certified. Licensed in those states. So you had to look at 50 different states and find the right person to come in to be part of this team.
Yep.
Right? Am I right on that?
And we had to make sure they were trained in the methods and the ways that we have identified to treat. It took 2.5 years. It took 2.5 years to build our initial team.
This couldn't have been a 1 month effort. It's had to be.
No, this is a long haul.
Right. And so now, and the vision is now to get more patients, is not to add more places, locations internationally.
Right now we will be bringing on new patients, right? So we are bringing on new patients. We have clinicians that are getting trained, so we can definitely flex and grow. And we're building the technology. And so we're staying in the United States right now. Now, personally, I would love to take this international, but each country has, and even like Canada's not all the same. Quebec is different than the rest. So they all have different licensures. We would love to be international at some point, at least our technology at a minimum, right? If we could get our technology and our training out there, that would be awesome. But really starting in all 50 states was kind of our first major hurdle.
So then how does Menrva fit with Living Well, the clinic that you started in Dallas? How do they integrate?
Yeah, so the clinic, we actually do a lot more than what we can do in telemedicine, right? So I have a DEXA device, I have a functional QEEG, we have psychiatry, so we are a multi-specialty clinic. And so Living Well Dallas is a separate entity, but it has been the think tank and sort of the center of excellence where we've developed our methods and really did the work, right? And so the 21 years and the tens of thousands of patients that we've helped over the years helped create basically the framework in which to bring Menrva to the masses. So to Living Well Dallas means you have to come and be physically present to be a patient there. Yeah, we do get people that fly in. So we have people that fly in. So they have to establish care by coming to Texas, or be in Texas. And then we do a lot of virtual outside of that. They just have to establish care and do physical visits from time to time just to continue to be able to be seen. So
what are some of the biggest challenges that are facing you right now?
I would say, it's always funding. Funding is very difficult for female-founded companies. We get less than 1%. Occasionally 1 to 3%, depending on what you're looking at, but we get almost no investable dollars, despite the fact that we usually outperform male-founded companies. And so, that's the biggest challenge, is having the right resources at the right time to build things, right? So that's been challenging, although we had a really successful friends and family round, and we're now, getting ready to go out and get another round of pre-seed investment. We are going to self-fund most of what's happening, though. So we're going to use our own revenue to grow. So we can grow organically and provide better value to our shareholders. So I'd say that's the challenge, because of course I want to see it out there. I'm one of those people that I already see the end point. I know what it's going to look like 10 years. I want 10 years today. And
well, if you listen, sorry, Betty, but if you listen to Ben Hardy, I don't know if you know Ben Hardy.
I love Ben Hardy.
Yeah, so he's been on my podcast and I adore him. And, he always says, if you think about what you want 10 years from now, you can be today. You just have to scale it. Yep. So he calls it a 10x or something like that. But so you're right in his camp. You're the perfect poster child for what he's preaching.
Absolutely. Yeah, I love Ben. Yes.
So, and we also have Tracy Wood is our common connection, right?
Yes. I've known Tracy for quite a while. She's so fun.
So check out Top Doctor magazine. She was just featured in one of I write a column monthly there for Top Doctor, and we just featured her. We featured Khan a couple of years ago, and that's how I got to meet Tracy. But so Tracy Wood, for everybody that doesn't know, is the current CEO of the DNA company, which is the genetics company that I tell everybody. That and Kim Ressler at SNP. Nutrition, Nutrinomics, those two companies are the ones that I recommend for getting your baseline foundation of your home, your health home, which is your genetics test. So those are two good ones. So where do you see the future of healthcare? You can't open the internet without seeing the different biohackers, and this is the best time to ever be alive. Don't die in the next 10 years, because the next 10 years, like the last 10 years, will be like the prior 100 years. So there's so much happening technologically and so forth. But what do you see personally for the future of healthcare?
Yeah, so I think it's several things. Obviously bioregulators, peptides. I'm getting involved with a group that's going to be doing an IRB, so an institutional review board, FDA research on peptides in our clinic. The reality is we have a lot of opportunity through technology to advance human health span. That's what's important to me. I don't want to live a long time unless I'm healthy.
Exactly.
Right? So it's the beauty is I think with all the different technologies that we have, we're going to advance human health for a lot longer health span. And I think it's a blending of the natural and the very cutting edge science, things like David Sinclair's work. We can't just look at it and go, I'm going to go get hemlock and some, holy basil, and that's going to make me live to 120. We need that other side of the technology. And so I think this is a beautiful time. And I think it's jumping in there and getting educated and being open to new opportunities on both sides of that fence.
And one of the things that gets me concerned is with all this technology, if people's attitudes towards coexistence, towards loving each other, towards being, whether you have a different opinion or not, that you're still willing to listen and tolerate and respect. And the connectedness is the fifth leg of that stool that they talk about with, when you talk about what are the influences on your longevity. Well, the connectedness is often one that doesn't get mentioned as much as your diet and your exercise and your sleep and so, but it's really important when they look at the blue zones. The fact that people are 100 years old still socializing and they still go out and walk together and so forth. This is something that I think our world today, being so divisive, is going to really hurt itself from an individual to a collective standpoint, because we're not getting along.
No, you're 100% right. Yeah.
And I just wish there were more and more emphasis on that.
Yeah, no, I agree. Yeah, I completely agree.
Are you familiar with Dr. Bill Lawrence?
No.
Okay, so he's Dr. Cavinson's protege. He went to St. Petersburg, knocked on their door. They took him in, they trained him, and they made him the U.S. representative for the peptide bioregulators.
Oh, okay, great.
So he's the man to know if you're going to start getting into, and I'm happy to introduce you if you like.
Yeah.
So I'm in his clinical trials. I've been in them for 3 years.
Oh, fantastic.
Because he was on my podcast through Phil Mickens, who... you can get a lot of peptides out of Phil Mickens' company, Anti-Aging Systems. But he introduced me to Bill Lawrence because he's doing the science behind all of this. And
that's fantastic.
So anyway, I really respect him. And a lot of people don't understand that you can get peptides orally if you don't like to inject.
Yeah.
And the peptide bioregulators have been in Russia for over 40 years. They've been selling them in pharmacy, so over the counter. So in Russia, they're considered just a regular pill, whereas here, they're still under a lot of scrutiny. But all those peptides that you get to inject, you can also take orally if you prefer that.
Yeah.
So anyway, but he does a lot of focus on ones like epitalin, which helps to, because he does his baseline test is to test your telomeres. And
Yes.
then the next, and along with that, your biological age. So let's talk about that for a moment, because that's always an interesting topic, is your biological versus your chronological. I think, honestly, Betty, I think if people ask you your age, you should tell them only your biological age.
I agree. I agree. Yeah. So the biological age is the aging of your system, not the chronological.
Exactly.
Yeah. No, I agree completely. At the end of the day, that's the one that matters, right?
Exactly, because your chronological age, I mean, yeah, you've been around the sun a few times, but if your biological age is 10 or 15 or 20 years younger, that's far more descriptive of who you are as a functioning human being than how many times you've been around the sun. So have you tested your biological age?
It's been a while. Yeah, it's been a while. My biological
Yeah.
age, last I tested it was like 48 and I'm 56.
Wow, that's
Yeah, so I was
incredible.
like,
Yeah, I think
probably depends on the year. Last year was a crazy year, so it might not be as great this year.
yeah, but still, it's at least 20 years younger than your
Yes.
chronological. So,
Yeah.
Betty, I was just signaled by Tony that we have to end because he has to go to another podcast. So I'm going to say goodbye to you, but I just want, before we go, I know you said you wanted to offer something to our viewers. So why don't you tell us what that is, and how I thank you very much for your generosity. So could you just give us a quickie on that?
Sure. It's an ebook. It's called The Fierce Female Method for longevity, and the URL is fierce. So the word fierce.hormoneshelp.com, and you can
Fierce is
download it.
FIERCE for anyone that doesn't know.
Yeah, I always have to write it down and look at it.
Yeah. Yeah.
But yeah, so
Okay.
it's got a lot of the information that we kind of covered today, and a little bit about how to biohack aging. And so thank
Do
you
they
so
need to
much.
use the ageless code to get the
No, that
book?
they can go straight there. Yeah.
Oh, okay. So they'll get it regardless. Okay, perfect.
Thank you,
Well,
Michelle.
I've so enjoyed having you on, Betty. I've been waiting for this for, I guess it's been like 9 months.
Yeah, it's been a long time.